This is Dr. Andrew Young at USC. This will be a slightly longer video. This will be more process oriented. We're going to go step by step through the process of a MAKO total knee replacement and how we take the three-dimensional images, then break them down into the coronal, axial, and sagittal, the femoral and tibial sides, and then look at how we can look at translation as well as rotation of the components to make sure that we've achieved a balanced and aligned knee replacement. So we're starting out with the radio. This patient has bilateral disease, but we'll focus mostly on the right for this exercise. This patient has lost joint space, has varus deformity, as well as a lateral tibial subluxation. And we'll go about characterizing this first on CT scan, and then we'll position our components to match this patient's anatomy. The CT scan will allow us to characterize both the femur and tibia and the relationships between each other, and it will help us identify any type of deformity that we should be aware of so that we can position our implants properly for maximum contact and the best meeting between the femur, tibia, and patella joints. And so we take a series of images. We can see the femur, we can see the tibia. This is anterior. As we're slicing through, this is posterior. This is axial, where we're looking at our patellofemoral joint, as well as the tracking of the patella. This shows us the tibia, which will be important in establishing tibial rotation. These are our sagittal views, both centrally as well as laterally. We'll then take those slices and then make a three-dimensional image, and then begin to characterize the rest of the femur. And so we'll characterize the top of the femur by looking at the femoral head. We'll find the center of the femoral head both axially and coronally, and then we'll find the center of the distal femur in three planes: axial, coronal, and sagittal. And then this will help us eventually to define the hip, knee, ankle axis in both the coronal and sagittal planes for the femur. Then do the same thing for the tibia. We'll have made a 3D model, and then we'll begin to characterize the tibia. First, we'll identify the proximal tibia and the important landmarks of the tibial tubercle, and then we'll define the distal tibia by finding the center. In this way, we can look at the entire shaft of the tibia anatomically rather than having to rely on secondary landmarks like the second toe. Once we've established our anatomy, we'll then have 3D models of the distal femur and the proximal tibia. And then we'll begin to make landmarks from which we will base the depth of our resection. We'll do that on the tibial side by looking at the medial as well as lateral tibia. We'll look at the posterior femur. This will eventually help us establish the posterior condylar offset. And then we'll look at the distal femur, and then that will help us determine the depth of our distal femoral resection. Our initial plan, and then this will be based on classic mechanical alignment theory. So we'll have this at 0 degrees of varus, which is equivalent to 5 degrees of anatomic varus. We'll have 8 millimeters off the medial femoral condyle, which restores the thickness of the implant. We'll have 0 degrees internal rotation relative to the transepicondylar axis, or 2 to 3 degrees externally rotated relative to the posterior condylar axis. We'll restore posterior offset at 8 degrees and make sure we don't notch, and make sure that we're appropriate medial lateral sizing. We'll take the same mechanical alignment principles on the tibia. We'll go 0 degrees of varus. We'll have 7 degrees off the unaffected side. Typically it's 9, but because this unaffected side also has 2 millimeters of cartilage, so that's how you get 7 off the bone. We'll go 0 degrees external rotation and 3 degrees of posterior slope. So this is our starting plan. This would be the plan if we were to pursue classic mechanical alignment with the plan of secondary releases to achieve balance. Robotic, however, we have an alternative of being able to make slight adjustments through the cuts themselves so that we don't have to rely completely on soft tissue balances from 0 degree alignment landmarks. And so we can do that first by characterizing the deformity in both extension and flexion. So with 0 degree mechanical alignment, we can see this patient has a 5 degree flexion contracture and 11 degrees of varus with a big asymmetry, with the lateral side opening and the medial side closing down. Then apply a corrective force on the knee. And we can see when we apply a valgus force, this deformity didn't correct. It started out as 20 on the lateral, 12 on the medial, and it did not open up. So this is a fixed deformity. And with a neutral mechanical alignment of the tibia and the femur, this would require a massive posterior medial release in order to achieve a symmetric extension gap. However, in this situation, I'll show you how we can make small adjustments in the tibia and the femur so that this gap can become rectangular with only a minimal amount of soft tissue release. Characterize the range of motion, and in deflection, this patient with this degree of deformity can flex to a maximum of 120 degrees prior to any releases or osteophyte removal. The first thing that we'll do is we will characterize our flexion deformity imbalance. So with the knee at 92 degrees of flexion, we will then look at our asymmetry of our flexion gap, and we can see we have a trapezoidal gap. We have 16 millimeters on the lateral side, 7 millimeters on the medial side. And then at baseline, you can see we have a very trapezoidal gap. We'll see if this is correctable in the next slide. Apply a corrective force to the medial side to see if we can correct this passively. But even with the corrective force, we can still see this trapezoidal gap, 16 on the lateral. This went from 7 to only 8 millimeters on the medial side. So with traditional knee replacement, when you place the tibia at 0 degrees of varus, you would have to do a very extensive release in order for this to eventually balance. The big breakthrough in robotic knee replacement is that it allowed us to make small adjustments with precision that are specific to the patient's anatomy, so that rather than having to place every patient at 0 degrees mechanical varus of the tibia and 5 degrees of anatomic alignment in the femur, we could make small adjustment based on the patient's anatomy. So all varus knees start out with this trapezoidal gap, where we're larger on the lateral side, smaller on the medial, both in extension and in flexion. And then we're able to make small changes so that we can get a rectangular gap in extension and a rectangular gap in flexion. And we can do this nowadays by making small changes to component position of the tibia, the femur, and in rotation of the femur, so that large releases are no longer necessary. We start this process always in flexion, and we'll make 2 moves in order to open this up. The first move we'll make is that we'll add slight varus. This will open up this side, add slight varus to the tibial side, and the second move is that we will begin to externally rotate this femur to open up this medial side. And then that way we can maintain the lateral side, but then open the medial side so they become equivalent. So that's 2 moves. It's adding varus to the tibia and then externally rotating this femur. And so in this specific patient, we started out with very tight medial side compared to the lateral side. And I'm looking at this area and I'm looking for symmetry. So the first thing that we do is we added 1, 2, then 3 degrees of varus to the medial side. And then we added 3 degrees of external rotation. And by making these 2 moves, we now have a balanced flexion gap, where we have 17 millimeters on both sides. This will provide our platform, and with this balance, we'll then move to extension. Extension always comes after balancing flexion. So we started out with 2 unequal gaps, we balanced flexion, and then our second set of moves will be make small changes on the femoral side in order to balance the extension gap so that it too is rectangular. And we already have set 3 degrees of varus from the flexion balancing. We still had a little bit of asymmetry, so we'll add 1, 2, 3 degrees of varus on the femoral side. This now corrects our medial and lateral distances so that they are equivalent. So now we have equivalent symmetric rectangular flexion gaps, and we have a rectangular extension gaps. Once we have these gaps, we will then try to make the 2 boxes symmetric. And so we had 20 and 17. So we'll open up our flexion space a little bit more by dropping this from 7 to 8. And then we'll also close down our flexion. This was 10 or 11 millimeters, and we brought this down to 7 millimeters. And so now we have pretty much near symmetry in flexion and extension. This is our plan. We actually haven't made any cuts yet. We've just looked at anatomic alignment. We've planned for mechanical alignment. We've assessed our degree of deformity, and then we've made small changes so that we can recreate rectangular and then symmetric extension gaps. And then we'll go back and then check each of these adjustments in 3 planes on both the femur and the tibia. So the first check is the anterior flange to make sure that we're going to not notch the anterior femur. 2 is looking at the sagittal image of the femur and making sure that we maintain the posterior condylar offset. This will be important in order to maximize the amount of flexion posteriorly so there's no impingement. 3 will be looking at the depth of our medial tibial resection. Remember, we used to be at 0 degrees where we were taking just 1. Now we've added 3 degrees of varus and we're taking about 4 millimeters off the medial tibial plateau. Scroll laterally and then we'll look at the depth of our lateral resection. We plan for 8.5 millimeters off the lateral side. 5 will look at the posterior tibia. 6 will then scroll forward to look at the anterior tibia on the coronal plane. 7 will look at the coronal image and make sure our implant still appears neutral, that the keel is still neutral, straight, and central in the tibial metaphysis, even though we put 3 degrees of varus of mechanical alignment. 8 will now assess femoral rotation. We're looking at the anterior surface of the femur, making sure that we have this piano sign. This is a very good landmark to ensure that we have adequate internal rotation so that we'll have appropriate patellar tracking. 9 will then assess our overall mechanical alignment. We started out at 10 degrees of 11 of varus. We're now down to about 6.5 degrees of varus. Come back to our femoral image on the axial view, and then we'll look at the trochlear groove and its relation to the patellofemoral groove. Scroll more distally, and then we'll be able to look at medial lateral sizing. This ensures that we have the proper fit in 2 planes. We've already looked at anterior posterior, and now we're also looking at medial laterally to make sure that there's no overhang. 12 we'll be looking at rotation of the femoral component. We already have very clear markers of external rotation, but here is the transepicondylar axis, and then we're making sure we are parallel or just slightly rotated to that. We'll then switch to the tibial axial image and make sure that we have the appropriate sizing with circumferential coverage for our tibial base plate. Is then looking at rotation of the femur and making sure that we're not internally rotated. 15 on the tibial axial image is making sure that we're in neutral alignment and not internally rotated. Once we've made these adjustments, we'll then take our probe and then make landmarks on the actual anatomy so that we can transfer this representation onto the patient's bone. We'll take a look at the center point as well as the 0 degree reference mark for the tibia. Now that we've confirmed the positioning of our components with 15 different checks, we'll then make our cuts and then place the trials. We'll then put laminar spreaders in place and then make sure that we have symmetric or restored symmetric gaps. So this is with the ligaments in tension. We have 19 degrees on both the medial and the lateral sides when the knee is flexed. Switch from a tensioner and then put a spacer block in to see how the knee is balanced at rest. This would then reproduce what the implant would feel like, and we have 18 degrees or 18 millimeters on both sides, which is our actual plan. And so we've restored the rectangular extension gap at 18 millimeters. And do the same thing in the extension. We have the limb out to a neutral alignment, and then we've restored a symmetric and rectangular extension gap of 18 millimeters, and this now matches our femoral gap. So now we have gone from trapezoidal gaps, which are uneven, to rectangular gaps to symmetric gaps in both flexion and extension. Then test the knee and hyperflexion to assess the end range of motion. We started out at 120 degrees. With these adjustments, now we're up to 136 degrees end range of motion. And then we'll confirm our image. So this is our post-operative image. Remember, we started out with the varus knee with lateral tibial translation. Here we can see we have a neutral alignment between femur and tibia. The components are well mated. The femur is centered and the tibia is perpendicular, and you have a symmetric extension gap. So that is how we go step by step to go from deformity to a balanced knee replacement. Thank you very much.